Thanks for joining us. Boy, this room feels almost like a church, you know, the stone walls and everything. I'm Clay Johnston. I'm the dean of the med school. And I want to thank you all for making it all the way down here. It's a bit of a trek, but it really is a beautiful place, and we thought this would be a wonderful setting to have this event. We realize, too, especially for the working folks in our community, that taking an entire morning off to drive down here would not be easy, and we worried that that would impact the size of the crowd, but it clearly has not. So obviously there's a lot of excitement and interest in hearing Amy Young talk. I'm thrilled that we were able to bring Amy to Austin. I just can't imagine a better person for this position. So Amy is from Jackson, Mississippi. All her childhood in Jackson, Mississippi. Her dad's a lawyer in a firm there, and doesn't sound like the kind of person that would have as much moxie as Amy does. But she told me a little bit more. They actually live in, what is it, the only Japanese-style architecture house in Jackson? So it's the only Japanese-style house in Jackson, Mississippi. So that tells you something right there. She's number 5 of 6 children. So if you don't have moxie, you probably don't get dinner. And then she decided she needed to get out of there as fast as she could. So she went to Vanderbilt for undergrad, came back to Mississippi for med school, and then from there went to a little detour to Emory and then to Baylor to finish her training. She did really well at Baylor, became vice chair at Baylor very quickly, had a lot of clinical responsibilities, clinical organization, and then was recruited over. Is that the rain? Wow. Then came back over to start basically afresh LSU after the disaster of the hurricane, and built that program to be really one of the strongest programs, and has had a lot of leadership roles nationally in the various societies for OBGYN. And I guess we're just lucky that you love to build things, because having built LSU back up, she was ready to come and help us to build something really great here. She warned me that most of the people that she's worked for have had to hold her back. They've told her, "You're moving too fast. This is scaring me." And I've shocked her by never saying that yet. And although she definitely pushes the boundaries on what she wants to get done, but that is exactly what we need from our chairs, is somebody who recognizes what a fabulous opportunity this is to get things right, working closely with the community, identifying the problems, and having the guts to go after what are going to be the most effective solutions. So I'm really pleased that she's here and very much looking forward to her talk. So thanks, Amy.
So before we get started, I just have to say that I'd really like to thank you guys for coming, especially fighting the rain, since we know we're going to have to fight. But I wanted to tell you a little bit about the rain. So I think I brought the rain to you from Louisiana. Every weekend, my family hasn't moved yet, and every weekend when I go home, the rain stops. And every Sunday when I come back, or Monday, the rain starts again. So hopefully I'm not personally responsible for filling the lake back up again, but I might have little something to do with it. I also am really excited to be here at this venue of the Wildflower Center today. It's really spectacular. I had not had the opportunity to be here before, but when it was suggested to me that this might be an appropriate place or appropriate venue for this talk, I was really excited. So as Clay already said, I went to Vanderbilt and I earned a degree, a double major in chemistry and biology. So at the end of my biology studies, I had finished comparative anatomy, and I just was determined I never wanted to dissect another animal again as long as I lived. And I had the opportunity to sort of switch out and do a lot of botany. And so one of my favorite courses, and the only book I actually saved from college, was my Taxonomy of Plants book. And so to have this special interest that I have and be able to be in this particular site is really special for me today. So I'm going to talk to you today about my vision for the Department of Women's Health at the Dell Medical School. And one of the things that happened fairly recently is we were the Department of Obstetrics and Gynecology, and then I said, you know, that doesn't really seem right. For this new medical school and for this paradigm shift in the way that we want to deliver care, we really need to be more encompassing of women's health because that's what it's all about, and I'll give you some evidence of that today. So we're now known as the Department of Women's Health, so we have a much broader, I think, expanse and focus across the lifespan of a woman, and that's what I'm here for. So I don't have any relevant financial disclosures. And so my objectives today are to tell you a little bit about me. Clay's told you a little bit already. I want to tell you a little bit about what I've learned in the community. I've been here on the ground since January 5th, kind of coming and going and spending some time working from New Orleans, but I've learned a lot. And so I've met with many, many people and have started to understand what are the pieces that we need to put together to make women healthier in our community. The goals for the Department of Women's Health are really simple, and they're really aligned with those of the medical school: to improve the health of all women across the life cycle, regardless of where they come from, socioeconomic class, color, and then to provide value and benefit to the people of Austin, Travis County. It's not lost upon me that this community wanted something new, something different, and something better for its people, and they were really willing to ante up for that. And so I feel a sense of responsibility to make sure that that happens. So Clay told you a little bit. I'm from Mississippi. I went to Vanderbilt, and then I went back to Mississippi to medical school. And my sort of vanilla background would lead you to believe that I would just go on to residency, but my life took a pretty big detour, and it has had big influence on me over the years. Let's step back a little bit. And that when I was in undergraduate school, I met my husband, and so instead of just going along and going through the normal career path of a physician, this detour led me actually way down south to Venezuela. And then, so I lived actually on the western coast of Venezuela, one of the largest estuaries in the world in Maracaibo, Venezuela. And so while I was in medical school, I lived actually in Mississippi, and we commuted back and forth for 2 years. And then I took 2 years off, had my kids, had health care in a foreign country. I had sort of the most amazing fragmented health care, in that I would have prenatal care in South America and then fly up and have a baby and then fly back to South America. But that really influenced the way that I started to look at healthcare and systems. I had the experience when I lived there of going to my doctor's office for my appointment, and this is, mind you, I paid cash, and this is the best person in the city, and there was a note on the door that said, you know, go on a vacation. If you have a problem, go to this hospital. So I actually firsthand got to see what this was really like. So after a couple of years, we went to Emory. I did my internship in Atlanta. Anybody that knows anything about Venezuela probably knows what my husband does for a living, and the oil rig count in Georgia was 2. And so there was an opportunity to move to Houston and to move to Houston. And as Clay said, I finished my training at Baylor College of Medicine and worked there in different capacities within the department, but also institutionally. And it's some of those institutional experiences that I have that I'll talk to you a little bit about that I think really, hopefully, have given me the skill set to come into this community and help women. I went to LSU almost for lots of unusual reasons, but LSU was recovering from the hurricane, and their care was as fragmented as it possibly could be. So basically, after the hurricane, there really wasn't a shortage of funds that were coming into the state, but the healthcare was really disconnected. And so I knew from my experiences from Baylor that I would have some of the skill sets that I needed to bring that community back together and help women. And so it was really intriguing to me, and so I went, and I've been at LSU. But what really drew me back to Texas and to the Dell Medical School was the opportunity to sort of shift from trying to fix things to actually create things anew. So to have the opportunity to work with folks like Clay and Kevin in the community seat in Central Health to really come up with something that is a model healthcare was really important to me, and it was too intriguing to pass up. So I'm really happy and feel delighted and lucky that I'm here. The other thing that you should know about me is that I'm a general obstetrician gynecologist. So it means that I have practiced and worked every day providing health care to women across the full spectrum of women's health. It sometimes is a positive and sometimes is a negative that I didn't subspecialize. But the good thing for me is I've been exposed to the wealthiest and the poorest patients. I've been exposed to patients and caring for patients of all races and ethnicities. And one of the beautiful things about my experiences is I've been able to do all of those things in one day. And not only does that lend itself, I think, to looking at things from a little bit different perspective, I've built programs along that continuum. So the programs that I've built, and we'll talk about some of those programs today and what I want to help build in this community, but you know, everything from reproductive health programs all the way to behavioral health implanted in a reproductive setting. So I'm going to shift a little bit and talk to you about why we need a new healthcare model. And so I'm going to tell you a little bit about you. You might mean the world, you might mean our community, and I'll show you a little bit of that evidence. So we're not doing as well as we should be. Our Canadian, Japanese, and Japanese actually have a very, very simple system for prenatal care. And I'm using maternal mortality not because I'm specifically interested in it, but it's just representative of where we stand with women's health in this country. So if you look where we are, we're not doing better than a lot of other developed countries, and actually we're doing worse over time. So as you can see, the rate of, or the maternal mortality ratio in the United States has more than doubled over the last 25 years. So there's 3 reasons why we postulate that this is actually happening. The first is our data collection is a whole lot better. There's been a lot of emphasis around maternal mortality, and so we're counting better. Many of the states have put in changes in their birth certificates. Texas did it as well, I think in 2011, and so we're counting actually just a whole lot better. But we really are doing worse, and where we seem to be doing worse is twofold. One is we have lack of standardization of the care that we provide, and then the second thing is that the patients that we take care of are just fulminantly sicker than they were in previous years. We also have a significant racial disparity in maternal mortality in the United States. This is basically looking at a 5-year period, but if I go back 10 years or 15 years and showed you that data, it would look exactly the same. We are not making headway into our different populations and actually recognizing that. To the point of standardization, if you look at what the causes are of maternal mortality over the last 25 years, and this is all from basically the CDC, on the left-hand side, you can see we've made great strides with hemorrhage. And that's where we've really standardized care within the hospital setting. We've developed mass transfusion protocols, drills, and so we've really made great headway there. But if you look over on the right-hand side of this particular slide, you'll see that we have a long way to go with patients that have pre-existing medical conditions. So we're doing worse as far as cardiovascular disease, cardiomyopathies, stroke, as well as non-medical or non-vascular medical conditions. So we have a long way to go in this particular segment. And so we've got to really work on trying to help women become healthier before pregnancy. And I thought I would illustrate this with a story. This is actually a real patient. I won't disclose the location of this patient, but I came in to take my labor and delivery shift. And the consultant the maternal fetal medicine consultant had recommended continuous fetal monitoring for this patient. The infant was noted to be growth restricted and have absent end diastolic flow. So for the non-medical people in the room, that just means the baby wasn't being perfused very well, and we needed to monitor the baby and basically take the baby out when it got sick enough. But when I went and looked at the record, I found that she's 21 years old. She's only 32 weeks gestation. She's HIV positive. She had other sexually transmitted infections. She had gestational diabetes, already had well-established chronic hypertension, and in this particular case, she had superimposed preeclampsia. And then when I went in her room, she weighed about 300 pounds, and I saw that she had this trach scar basically on her neck. And this particular patient had had a trach because she had sleep apnea so bad that she couldn't breathe when she laid down to go to sleep at night, and that was the solution for her. And they told her if she lost 100 pounds, they would basically pull that trach and close her. She did that, and nobody managed her contraceptive during that period of time, and she got pregnant, and at the end of the day, we ended up with probably a premature baby because of preventable conditions in the mom. And the future for that particular woman at 21 years that already has all these comorbid conditions is significantly concerning. So Texas has the same problem basically the United States does. So this is data basically through 2011 that came out in the state of Texas maternal mortality report. A task force was legislated in 2013. I think the bump is really related to a much better job of diagnosing and changes in the birth certificate, but you can see that we have a significant racial disparity in outcomes. Now, it's really hard to look at this on a county basis, so I'm kind of going to switch gears on you and show you some other maternal outcomes and show you how we're doing here in Travis County. Just in general, sort of an overview of the county is that we have a healthcare district like a lot of cities and counties in the country. We have 2 major hospital systems. There's about 20,000 deliveries annually in the county. They're continuing to decline a little bit along with the U.S. Birth rate. We have primarily mega practices that provide care to the insured population. So just some background numbers that I think everybody should know that's interested in women's health. About 35% of our deliveries are Medicaid deliveries in the state of, in the county. In the state, it's about 55%. And just to put that in perspective, when I was in Louisiana, that was 75%, and New Orleans was about 80%. So it tells you a little bit about the population. So we should do, if you use that as a surrogate for health, we should do a little bit better with some of our maternal outcomes than we're actually doing. But one of the things I found is that we have 4 or more disconnected electronic health records that I use in the care of patients every day. And so for some people, that's actually more. So we do have a big disconnect and a lot of work to do. If we look at STI rates, just to look at a surrogate marker for the health of the women in our area, we don't do as well as Texas overall. This is actually a slide actually depicting chlamydia rates here in Travis County, but this slide looks almost the same for gonorrhea or syphilis. It's really no different. And if you think it's really our male counterparts, it's really not. So you can see from this slide that it's a very significant problem for the women in our community. If you look at maternal child health indicators, you can see that there's a fairly big disparity as well with preterm birth and low birth weight infants. We are doing better than the state as a whole, but if you look back at the previous 10 years, we really haven't really affected those rates very much. And if you look at some of the data from Children's Optimal Health, I'm a map person, so I'm a visual person, so it really lets me have insight. This is actually the count of births admitted to the NICU based on census data. And it doesn't really matter if you look at any adverse outcome related to maternal child health, it looks the same. We have a very significant problem in East Austin and Northeast Austin that we really need to address. And it has to do with health disparities and social determinants of health. And this is an area where we're going to have to make great impact. And part of that is why we named the Department of Women's Health and not just obstetrics and gynecology, because we really have to look at these other things if we're going to create a model healthy community for women. So I'm going to talk to you a little bit about some of the things I've done and some of the things that we're doing, but I'd like to couch it in the life cycle of a woman. I've sort of used this analogy for a long time. I say I used to talk about it linearly, but as I've gotten older, I really like to talk about it in the cycle because it makes me feel a little bit better. But if you think about where most of the focus in women's health is, it's actually around these issues of the procreative years. So pregnancy, family planning, and infertility actually plays a smaller role. So we're going to talk about this particular segment of the life cycle of a woman first. One of the things I'd like to point out to you is this piece is usually about 30 years, maybe 35 years in certain cases. And so the idea that there's so much focus around this one particular issue and not around the rest of the life cycle, which represents about 50 years, is somewhat problematic to me. And it's illustrated by the patient case I told you about earlier. So one of the reasons why there's so much focus on this particular portion of the life cycle has to do with really cost, NICU admissions, and cost of prematurity. The cost, as reported by the March of Dimes in 2007, was $26.2 billion. About 60% of that is related to NICU cost, and the rest is taking care of ongoing problems related to these neonates. So it's really not a big portion about what we spend on health care. But it's a little bit more than 50%, $50,000 per preterm birth. If you put that in relation to what we pay for maternity care in the United States, we pay about $60 million total for maternity care, and we deliver about 4 million babies, so we're spending about $15,000 per baby that we deliver, but yet we have this problem on the back end that we're spending $50,000 on a preterm neonate. The other reason there's a lot of focus around this particular issue is there are political and religious concerns that we have to balance. And then there's a real frustration on interactability of challenges. The March of Dimes have come in full force. Good news is in Texas we've gone from an F to a C, and I think based on the most recent data we're doing a little bit better, but we still have a long way to go. So we have nationally really started working on standardization and minimal standards. So the hospital associations have done a lot of hospital driving with having to report data. So we have mass transfusion protocols, hypertension protocols, simulations ongoing, and our specialty societies and OBGYN have gotten involved most recently. So whereas for a long time there have been neonatal levels of care, just as of February this year there are maternal levels of care. So if you have a sick mother or a mother with comorbid conditions, these levels of care are being rolled out so that we can deliver the mom in the most appropriate place. And then there's been endorsement of practice guidelines and checklists and the creation of these to try and help standardize that care throughout. But we still have a long way to go. Now we have new interventions and treatment. So if you look at what's happened in the last 20 years in obstetrics and gynecology, those things are on the left-hand side of the slide are things that are really directly affecting obstetric outcomes. There's some crossover, and on the right-hand side are those really advances in gynecologic care. But if you notice, none of those has anything to do with healthcare delivery except for centering pregnancy. So if we don't think about the way that we deliver care and actually get care to the right place, we don't have the ability to deploy any of these interventions to actually result in enhanced outcomes. And so that is essentially why I'm here. Now, part of the reason that we have this issue is that we have a chasm of care in women's health care, specifically in many states, but we really have a problem here. So care gets provided to women episodically through pregnancies and for a very short interval through the postpartum period, and specifically our sickest patients are in this sort of situation. And then we don't provide any care in between those pregnancies. So our opportunity to really intervene and improve the health of that mother for her own sake and for her future offspring is actually lost. The problem is actually even a little more serious. I mean, this is the way that you usually see it presented. So we have basically care in these chasms of care that I've already showed you, but I actually think of them more as canyons than chasms of care. Because what really actually happens is that you have these brief interludes where patients and women have care, and then you have long periods where they don't have care. So we don't really as providers have the ability to intervene. And it's something that I hope we can work on. When I was in Texas before, I tried to work on linking the women's health program to women that had adverse pregnancy outcomes, so that when they came off of Medicaid, that they would automatically be enrolled so that we could address some of these health issues and health disparities. Unfortunately, it didn't work. I'm not done trying though. I do want to tell you another patient story that illustrates this, and this is a fairly recent patient. On call, I was called to see a patient that was 17 years old who was admitted to the ICU for sepsis after she almost died after a septic AB. The interesting thing is that this patient in the prior year had a previous loss at 14 weeks. We know that there are things that we need to do to try and discover and ameliorate to prevent this from happening again, but we missed our opportunity in this particular patient because she fell out of the healthcare system. Now, she likely has a Müllerian anomaly, and for those of you that are non-gynecological in nature, it's just basically a deformed uterus. There's different varieties of which, but she probably likely has a septum, which is a really simple outpatient opportunity or outpatient surgery to fix. But in this particular case, we don't really have the ability to make the diagnosis and actually treat this patient. So when she comes out of the hospital, we've been sort of racking our brains about whether we can provide this support for this particular patient while she's in the house, and what is the science behind that, because we're afraid that once she goes out again, we won't have the opportunity to intervene. And if she continues down this path, she'll eventually probably get to viability and will not have a loss, but she's not going to have a term baby given this particular scenario. So we've missed a lot of opportunity to affect cost and bring value to this particular patient. So I'll talk to you a little bit about previous experiences, and I only tell you these because I think these are examples of sort of my skill sets and what I bring hopefully to the community and to the medical school. So I worked, the last 2 years I was at Baylor, I was the service chief for Harris County Hospital District, now known as Harris Health. And probably the second day I was there, I had these women come into my office and throw this map down on my desk and say, you know, we have this terrible problem on the south side of Houston. So the south side below 59 was essentially my responsibility. But they said, we have this terrible problem, what are you going to do about it? And so I started looking at this and said, well, I could see the clinics actually mapped out on this particular map. And I said, but I don't think we actually provide services in this particular area. So I went outside in the hallway, got the map off the wall, superimposed this map, and clearly we weren't providing any kind of women's services in the population that was most at risk in Harris County. So I was able to use that to negotiate to put a provider in this particular area to provide not only obstetric care, but contraception and meet the other women's health needs in this particular site. We also worked as a team to develop an integrated obstetric service delivery line and develop comprehensive ultrasound services, which was sort of the community standard for the insured population, but wasn't for the uninsured population. And so we were able to make the case that providing ultrasound services would actually save money in the end, because the downstream effects of not being able to date a pregnancy was not cost effective. We were able to demonstrate that 40% of our patients that presented in the first trimester had wrong dates by more than 8 days. And so that was basically the argument that allowed us to do this. The other kind of unintended advantage of this is that we were able to manage first trimester pregnancy losses for our patients in a much more humane way. So once we knew that a patient had miscarried, we were able to find it a lot earlier and give the patient options and choices for her care management other than just dropping in the ER when she was hemorrhaging. So the way that this work started was, as I was approached to say, you know, we're losing our market share with obstetric deliveries and we need to figure out why. So the first question I asked was, well, how do patients know where they need to go when they're going to deliver? And I was handed a photocopied Google map and said, this is what we actually give our patients. So we had a lot of work to do. And my team, we actually brought in the UT physician on the other side of the healthcare district, created an integrated obstetric service line that actually exists today. And this is just one example of the Visio document that basically appears seamless to the patient, but is all the work that goes on the background in navigation and scripting to be able to provide those services. We also did something else that is unique, and unfortunately I left before I could see this come to fruition, but we used actually inpatient outcomes to measure the success of our integrated delivery service. And that seems kind of odd, but it's something that's critically important. There's only so much you can do based on what I've already showed you when the patient gets to the hospital, so what are we going to do before? So as Clay told you, and then I moved to New Orleans, and I've talked to you a little bit about that. This is actually pictures in 2005. The clinic that you see on the left is the clinic where we basically saw patients, so it was a foot underwater. That downstairs now is a centering program. And the picture on the right is actually looking back at Charity Hospital. So the city was just devastated. But again, we got to do some really unique things. And because I had had this experience actually building mother-baby medical homes in Houston, the plan was to go to New Orleans and do the similar thing. And then when I got on the ground a little bit, I looked around, there had been all these clinics that were established, but they had no linkages. So there was no way to actually link to a higher level of care and get the services the patient needed. They kind of stayed in their medical home, and there was a great deal of competition for patients between those, but there was no linkage. So I said, okay, we're going to figure out how to do this. So luckily the ACA came out and actually empowered us to do some things that were different that nobody had really done before. So the ACA allows residents that are paid for by a hospital to work in a clinic as long as they're in affiliation between that clinic and the hospital. And that had not actually been exercised in Louisiana. We were also able to move residents from one hospital to another, which increased the revenue that that particular hospital got. So they were interested in doing it to move the residents out into the community. So we created new relationships with the FQHCs, and I'll show you all of those in a minute. The FQHC funded my faculty, which was a problem for me. We created more deliveries and inpatient services. But at the end of the day, the thing that was most important about this is the patients. We were able to provide care for them in a connected way that had not really been able to be done previously. Patients just sort of showed up at the hospital to deliver, or when they were at sort of an end stage of a disease. And so this is a model that's been adapted by other departments within LSU. And this is just an example. One of the things is we try to make connectivity with computers, but real people actually make a difference. So when I first went to LSU, all we had was the Perdido Clinic. And just for fun, Perdido actually means lost in Spanish, and I could not figure out why we were sending patients to the Lost Clinic. You know, who could come up with the worst name? It turns out it's the name of a street, and it's on that street, which is why it's Perdido Clinic. But all of our services were located right in the middle of those floodwaters that I demonstrated to you. And so doing this new, understanding really the healthcare economics and what was possible allowed us actually to grow our footprint across that. So this slide is actually sort of upside down. Since New Orleans is the Crescent City, I should flip it the other direction. So all of these clinics are actually not related. And that what happened is when we came on and standardized care and referral guidelines, we had the ability to have other clinics approach us because we were giving something that other people didn't have. So we implanted faculty and residents basically across the city and connected those dots and integrated the delivery system. So in Austin, since January, I've been working with Seton and Community Care and the CCC to help create an integrated delivery model for obstetrics here. And once we do obstetrics, gynecology will just sort of naturally follow. It includes a comprehensive ultrasound program like I described for the district. And this is actually a schematic of the plan. Now, I know that looks crazy with all these arrows, so I'm going to simplify it. But basically, our plan is to standardize care, push more care back into the patient's medical home, improving access for patients, but also standardizing referrals and actually scripting and standardizing that prenatal care. You keep hearing the standardization over and over again because it's what we need to do. So basically, a patient will come in, have accurate dating, be screened by an obstetrician gynecologist, and then be referred into the appropriate care for the rest of her pregnancy. And if she falls out, we will be able to co-manage, which is what all those arrows mean, or be able to refer to a higher level of care. This is important for two reasons. One is that with the FQHC model, we will be able to provide care for patients in that interconception period where their health is so important in the preconception period. And then the other thing is that I came here because I really want to innovate new models of care. And if we don't have sort of the Maslow basic part, I mean, this is sort of a big metaphor, but if we don't have a basic infrastructure in place, we're not going to have the ability to actually test those new models to make sure that we are actually helping patients and not harming them. So I'm going to give you an example of what is possible. So what is possible is that right now the way we manage obstetrics is every patient is sort of a black box. Some of my maternal fetal medicine colleagues in the room may beg to differ a little bit, but we kind of reinvent the wheel with each and every pregnancy. And we know that there are social determinants of health as well as the patient's past medical history that likely influence that outcome. But we sort of start, we do the regular 12 or 13 visits. Things have changed. We have access to technology that can actually help us, but we still sort of do the same thing we always have. And what I would tell you is that we have opportunities. So we know that if that patient has a good outcome, she's not as likely to have a bad outcome in a subsequent pregnancy. So the ability to tailor care after she's had a good outcome is better, and if she's had a bad outcome, what does that really mean to us as far as managing her subsequent pregnancy? So if we're only going to have $15,000 per delivery in the United States, should we apportion less for people that we know have good outcomes and tailor their care and more to those patients that really need it. If you look at, just at preterm labor as an example, if you look at really old data, and this is actually Scandinavian data, but it's been redone here in the United States, if you have 2-term deliveries, you're not likely to have a preterm delivery in the future. So do we really need to provide care the same way? And if you've had 2 preterm deliveries, you have a really high chance of having a preterm delivery. So we need to potentially manage those patients differently. So I am going to shift gears just a little bit and talk about menopause and postmenopause, and I'll talk about this just really, really briefly, but talk to you about some of the programs that I would like to create. These programs are really clinical care programs, but there's research and educational components that go with this. So if you think about it, this is one of the craziest slides ever. So at the turn of the century, the last century, not this one, basically life expectancy was only 48.3 years. So menopause and postmenopause probably didn't matter quite as much because you basically didn't really get there, or you barely got there. What this slide tells you is the longer you live, the longer you're going to live. That's all it really means. But that means that we can't make assumptions based on women based on their age as far as care, complaints, and issues that they potentially have. We do sort of do traditional care for women in this age group, cancer screening. This whole issue of how we do HPV testing now really opens a door to really new paradigms in the way that we deliver care. We provide cancer diagnosis and treatment. We've traditionally evaluated patients and worked with patients around pelvic organ prolapse and incontinence. I have this question, what do we do with the annual exam? Is there any evidence for it? There may not be evidence for it, but the relationships that you create longitudinally with women actually matter. So we need to make sure we don't lose sight of this as we start to do healthcare redesign. So consistent with the school's mission of evolving new models of person-centered and multidisciplinary care that reward value, some of the things that are on the table for us are the creation of multidisciplinary, non-traditional centers of care. So we really need to focus on the science around menopause and perimenopause. All of these are sort of overlapping, but sexuality, where are we with sexuality in our community? Pelvic pain, endometriosis, other pain syndromes. We know from other institutions that the best way to do this is a multidisciplinary approach. And vulvodynia and vulvar dystrophies also sort of fall into this group where there's some interconnectivity and some potentially shared resources. And these kinds of things are going to be very important in supporting the Cancer Center when it comes up. If we think about going back to the life cycle actually prior to the procreative years, I want to talk a little bit about in utero development and some opportunities that are open to us in pediatric and adolescent gynecology. Since 1995, we've had the ability to laser twins for twin transfusion, and we've come a long way. But with the MOMS trial and the ability to close myelomeningocele in utero and actually have better outcomes for babies, it's really, I think, pushed the thoughts and how we can do fetal surgery to the forefront. But the problem is that nobody really talks about in this study, yes, it was better for babies, but the maternal morbidity that resulted from this was actually much greater. So this is a big decision for families and mothers. And so one of the opportunities I think we have is to work with the School of Engineering and others in the institution to develop minimally invasive tools and techniques so that we can actually do these procedures where it's safer for the baby and safer for the moms. The other opportunities that we have is to really think about this in utero environment. We need to work with our colleagues in pediatrics to better understand the nutritional impact. So the data is emerging, and we know that there's epigenetic modifications of those babies in utero that not only affect their own life, but are actually heritable and passed on to their offspring. And so we will need to work intensively in this particular area. Pedi and adolescent gynecology is near and dear to me. I helped bring up a program, and I've been able to see what the value that it brings to the community. There are all these conditions that there is some overlap with our colleagues in pediatric urology, as well as with adolescent medicine, but we sort of have a different lens that we look through to look at these particular problems and concerns that young women have. And I've seen by bringing this up before what happens in the community, that this is a resource that we currently don't have and that we currently need. The other role that these folks play is actually in cancer survivorship. The advances in egg vitrification, ovarian harvesting, and reimplantation really opened up the door for us, really for all patients. So the way that this used to go, and there's been guidelines by ASCO since 2006, is you went to talk to the patient to see if they were interested in oncofertility, but they didn't have any resources, so you couldn't really offer them anything. So that day is actually going to change, probably especially through ovarian harvesting and reimplantation, because it's a much more cost-effective option for these patients. But also, as these girls that have gone through early menopause, how we manage their sexuality and the menopausal symptoms and their future lives, because they have survivorship, will be important as well. So I have sort of gone around the life cycle, and you've seen these words in the middle of this slide. I mean, essentially, genetics touches pretty much all of these nodes: ethics, cancer, health literacy, and behavioral health. And there's probably a lot more that belongs in the middle, but for the sake of brevity, I've put those there. I just want to share with you one other program that I've helped to bring up, and I think it's something that's really important, and I think that we have a unique opportunity in our environment to do this right from the very beginning. So reproductive behavioral health is very interesting to me, and so I've had the ability to bring up or place reproductive behavioral health in reproductive clinics, reduce the stigma, and improve the access in my 2 previous institutions. And this work started, and this is unpublished work that I'm sharing from, she was Dr. Zogby, now she's Dr. Smith. But we queried all of the OBGYN providers in the state as to what their practices were with postpartum depression. There was a study from Washington done about 5 years before that showed that basically half the cases of postpartum depression were actually going unrecognized and untreated. And with the whole focus on Andrea Yates, I thought surely that can't be true here in Texas. So we queried all the OBGYNs, and basically what we found was something very similar. We found that basically 81% of the OBGYNs in the state thought that they screened, but only about 30% of those that screened use a validated tool. So about 25,000 women and families were going untreated annually because we weren't really creating the screening practice. So we've gone on to do educational programs around this particular subject. It's interesting that our data actually exactly mirrors the Washington State data from 5 years before. And we've got a paper being submitted right now that looks actually at pediatric outcomes and pediatrician behaviors. And they've had a recommendation by the AAP for a long time to screen all patients when they come in, and their data looks almost exactly the same. So education's near and dear to my heart. Clay talked about that just a little bit. One of the, I think the easiest, and I shouldn't say easiest because it's going to be a lot of work, but best ways to help us raise a level of expertise and create a pipeline of providers here is to bring on fellowship programs. So that's in the plans. But for fun, this is Dr. Johnson calls this my fun project. One of our missions is to produce future medical leaders. And so those are physician scientists, but they're also leaders across the continuum. And I think here at UT, we are poised to have the ability to really create unique programs. Between the seminar programs, the master programs, and the PhD programs that are offered across the campus. I mean, traditionally, MD PhD programs have been things that were at the undergraduate medical level, and in some cases there's an opportunity to do this at the fellowship level, but there's never been sort of the opportunity to do this at the residency level. And so I hope this is something that we can pilot and then push out across the country and across the institution to other specialties. So I think our vision for women's health is just very consistent with that of the medical school vision. We're inclusive, it's dynamic, and it is something that we're going to do to involve the community to better the health of everyone. So we want to revolutionize the way that women get healthy and stay healthy. We want to address this interconception period, help women have babies that are healthy, but also help women stay healthy. So we have a lot to do to create outstanding women's health programs across the cycle of women's health. And we want to do that for her no matter where she comes from, whether she's insured, not insured, what she earns. And then I'd like to close, I want to tell you one other thing about me. So I have two favorite words in Spanish. Part of those, they're just really hard to say, and for a girl from Mississippi that sort of had to learn a new language on the fly, you can only imagine. But if I knew you better, I'd tell you the funnier story. But the two words that I just really, really love are murciélago, because it's a hard word to say, and anaranjado. And can you imagine my delight when I come and the very first thing I see when I get out of the elevator is a sign that says no toque los murciélagos. It's actually in Spanish before English. And the thing that I really love about this sign is that the bats are smiling. Now, I think because anaranjado is one of my favorite words, it means orange, I was destined to come to UT. So this is my 12-year-old the day that I told her officially that we were coming to UT. So thank you very much for your attention. Please help me, because it's going to take all of you to help us really push healthcare forward in the community. And so if you will share your wisdom with me, I'd greatly appreciate it.